Welcome to the GEMS video, which is primarily this month aimed at physicians. I will be discussing on the cardiovascular outcome trial with Empagliflozin, and this EMPA-REG outcome trial results were presented in the month of September 2015 at the EASD meeting. And this is on improving survival in type 2 diabetes, a landmark clinical trial. And these are my disclosures. In India, this is the reality with diabetes. Despite the availability of all medications, the cheap medications, the expensive medications, the technologies, old and new, the A1C remains very high. In the north, in the south, in the east, in the west, the average A1C is above 9.3%. And these are some of the publications. And this is from Dr. Mohan and his group from Chennai. The complications of diabetes in India resulting from uncontrolled blood sugars. And these are the cardiovascular complications, the microvascular complications, and believe me, these are in millions. And we are justified in accepting newer medications. And recently we started using SGLT2 inhibitors. SGLT2 inhibitors have their origin from apple tree bark, and that was way back in 1835 when the French chemists extracted fluorescein from the apple tree bark, which was a non-selective inhibitor of both SGLT2 and SGLT1. SGLT1 inhibition in the intestines might result in abdominal discomfort, and years later the new drugs were developed, and now in India we have, in addition to Empagliflozin, we have Invokana, we have Foxica, and these medications as a class, they have a very unique mechanism of action, and they have already proven their safety and efficacy, and hence we have accepted. And from apples and apple trees, let us shift our attention to protecting the heart, and that is the close connection between diabetes and cardiac ailments. This is the normal life expectancy of an individual without diabetes, and with diabetes there is a reduction in the life expectancy by 6 years. And with this deadly combination of diabetes and myocardial infarction, when an individual with diabetes develops a myocardial infarction, the life expectancy gets reduced by an additional 6 years, and it amounts to 12 years. So life expectancy is reduced by 12 years in diabetes patients with a previous history of cardiovascular disease. And historically we were concerned about drugs as the cause of heart attacks and heart attack induced deaths in diabetes. And it all started with Dr. Stephen Nissen at his Cleveland Clinic, along with his biostatistician Kathy Wolski, when back in 2007 in New England Journal of Medicine they published a meta-analysis and tried to prove that rosiglitazone increases deaths due to heart attacks. It shook the world like a tsunami. All the physicians were in confusion, and this controversy resulted in the FDA announcement and the mandate of recommending cardiovascular trials for all diabetes drugs, irrespective of whether it is an injection or an oral therapy. This is a statistical definition of a cardiovascular outcome trial. Before submission of a new drug application to the FDA, the sponsor should compare the incidence of cardiovascular events of the trial drug with that of a comparator or with a placebo. And this is the 95% confidence interval. The upper bound of the two-sided 95% confidence interval for an estimated risk ratio should be less than 1.8 to accept the drug. If the hazard ratio is between 1.8 and 1.3, the drug need to go through a cardiovascular outcome trial to prove that it is neutral in contrast to the placebo. If it is above 1.8, it becomes non-approvable. And already we do have some of these landmark clinical trials already published, and these are some of those trials already published. Sitagliptin with saxagliptin, examined with allogliptin, the sitagliptin outcome trials, that is a TCOS, and then we have the Alexa, that is with lexisenatide, which is an exentin derivative. And all these clinical trials looking at the cardiovascular outcomes have shown a cardiovascular safety. They have all showed that they are neutral, but none of them have proven that they are superior in reducing the cardiovascular events in patients with type 2 diabetes with high cardiovascular risk. And it is under these circumstances we are going to discuss the Empagliflozin, the Jardiance cardiovascular outcome trial. And this is the overall design. It is a randomized, double-blind, placebo-controlled trial. And this trial is designed with an objective to examine the long-term effects of empagliflozin versus placebo in addition to the standard of care for diabetes on cardiovascular morbidity and mortality in patients with type 2 diabetes and very high risk of cardiovascular events. What is empagliflozin? Empagliflozin is another SGLT2 inhibitor. It is a sodium glucose co-transporter in the kidney, and it reduces glucose levels in the blood by reducing the renal glucose reabsorption, enhances the glucose excretion through the urine, and it has been proven that empagliflozin will result in significant reductions in the A1C. It will result in weight loss, and it can reduce blood pressure without an increase in the heart rate. And these properties are of course shared by the other gliflozins already available in the market, the canagliflozin and the dapagliflozin. EMPA-REG was a truly multi-centric, multinational trial which enrolled over 7,000 patients in 42 countries in 590 sites with a true representation of more than 200 subjects from India. So this was the overall trial design. 11,000 plus patients were screened and 7,020 patients were randomized, and they were randomized to either the placebo arm or to the EMPA-10 or to the EMPA-25 milligram arm, and these were on top of standard of care. All these patients were on therapies for diabetes and for therapies for their hypertension and for their cardiovascular risk, and the drug, whether it is placebo or EMPA, they were added on to the existing standard of care. And this trial was so unique that more than 97% of subjects completed the trial, and more than 99% of patients had the vital stats available. And all the patients were those with diabetes, uncontrolled diabetes, and with very high cardiovascular. So these were the inclusion criteria. Adults with type 2 diabetes, BMI equal to or below 45, A1C between and inclusive of 7 and 10%, and with established cardiovascular illness, and an EGFR as per the MTRE below 30 ml per minute was a key exclusion criteria. And all the outcomes were pre-specified, and these were the primary and secondary key outcomes. This is a 3-point MACE, major adverse cardiovascular events, and 3-point MACE were timed first occurrence of CV death, non-fatal MI, or non-fatal stroke. And key secondary outcome, the 4-point MACE in addition to the 3-point MACE will include hospitalization for unstable angina. And these were the further pre-specified outcomes, and these were the parameters which were additionally analyzed. The statistical testing strategy was highly planned, and an analysis was carried out as a pooled analysis of both EMPA 10 and 25 together versus placebo in an intention to treat population. And intention to treat population meant patients who were randomized and taken at least one study drug. And all the events, the primary events, the secondary events, were all adjudicated by independent clinical events committee. And in addition to that, the cardiovascular outcome analysis was independently validated by one of the top universities specialized in statistics at the University of Freiburg in Germany, so that it is totally independent and unbiased. Statistical analysis was again based on a hierarchical fashion, starting with non-inferiority for 3-point MACE, and once it is tested positive, moving further on to non-inferiority for 4P MACE, and then next step will be superiority for 3P MACE, and ultimately superiority for 4P MACE. And what are the baseline characteristics? It was a truly multi-ethnic population with a distribution across the world, and these were the baseline characteristics of the study population. And this is the A1C. Over here you have the placebo arm, and this is the 10 milligram EMPA arm, and this is the 25 milligram EMPA arm. Close to 60% of patients had a duration of diabetes of more than 10 years. And at baseline, as we can see over here, approximately 50% of patients were already receiving insulin, and the average total daily dose of insulin was around 65 units. And these were the baseline cardiovascular risk factors. Many of them, or most of them, were obese or overweight. And with regards to systolic blood pressure, with regards to LDL cholesterol, they were all under control. They were under stringent control at baseline itself. And here again there is a true representation of all the categories of renal involvement, with more than 25% of patients being represented in every arm for an EGFR below 60 ml per minute. And these are the baseline characteristics on cardiovascular complications. More than 75% of them having coronary artery disease, and almost 50% of them having history of MI, approximately 10% of them having a history of cardiac failure, and 80% of them were already on ACI or ARBs, and 42% of them on diuretics, and the majority of them, more than 75% of them in all the arms, were on statins, and more than 82% of these subjects in all the 3 arms were on aspirin. With regards to the years of exposure in this clinical trial, the observation period of around 3.2 years is more than the treatment duration, as patients who discontinued treatment were followed up till the end of the study, and all patients were followed up for 1 month after the trial completion. Moving on to the results of EMPA-REG outcome, it's really fascinating. let us move on to A1C first. Of course, HbA1c is not a criteria in this clinical trial since this is a cardiovascular outcome trial and all the patients were receiving standard of therapy. And this is the first 12 weeks of initiating the trial drug. Of course, there is a rapid reduction in the A1C which is close to 0.5% in contrast to the placebo arm. And from 12 weeks onwards, the investigators were given the privilege to add or delete a drug based on their discretion. They can modify the glucose lowering agents, they can modify the agents for hypertension or for cholesterol. And this is the change in the weight which started appearing at 28 weeks onwards, and the weight loss was maintained till the end of the study, and the average weight loss with EMPA was up to 3 kilograms, and this is with systolic blood pressure reduction with the EMPA arm up to 4 to 5 millimeters of mercury. And now we move on to the cardiovascular outcomes. And quite interestingly, the reduction in the systolic blood pressure has happened without any change in the heart rate, and this is as per the ECG readings. And let me move on to the much awaited cardiovascular outcomes. And this has appeared, the results have appeared in most of the newspapers across the globe since it was so remarkable. And this was a heading in the New York Times: Jardiance, a diabetes drug, cut cardiovascular deaths by 38%, the study says. And this is how it read: for the first time, a widely used modern drug for diabetes has shown to reduce deaths from cardiovascular disease, a long sought goal of treatment, researchers announced at the EAHD. So let me move on to the 3-point MACE, that is a primary outcome. There is a 14% reduction in the 3P MACE. And next, on the mortality. The mortality statistics, the cardiovascular death data from EMPA-REG outcome. And this is quite surprising. In contrast to placebo, there is a 38% reduction with both EMPA 25 and 10 put together, and this is a hazard ratio of 0.62 and a p-value of less than 0.0001. And these changes, quite surprisingly, have started appearing. These curves have started separating very early as 1 to 2 months of initiation of the clinical trial. And in the subgroup analysis of individual doses of 25 and 10 separately, the same has been observed, the same 38% reduction, and there was no difference between the two dosages of Empagliflozin. And when these results were announced at the EASD, there was a wide applause among the audience because of the surprise. This is the first time ever a glucose lowering agent in a clinical trial showing a reduction in the death due to heart attacks. And this is a subgroup analysis. The subgroup analysis looking into the age, the sex, the race, the A1C below or above 8.5, body mass index, the EGFR categories. There were no differences with any subgroups. The benefit of CVD was seen across the various subgroups, and the p-value for interaction was not at all significant. And this is the data on CVD, MI and stroke. Non-fatal and non-fatal MI and non-fatal stroke didn't significantly differ from placebo. So it was the same as the numbers in the placebo arm. However, there is a subtle difference in the hazard ratio for non-fatal stroke. It is 1.24. So let me dissect into the details. The point estimate of non-fatal stroke is slightly increased, but this is from the intention to treat population were events taking place even after discontinuing the study drug were taken for analysis. And here there is an on-treatment analysis where events occurring up to 1 month of discontinuing the study drug was taken into account, and then the hazard ratio is close to unity. It is 1.04, and 18 out of 21 events which caused this major imbalance was found to occur 3 months after discontinuing the trial medications. The percentage of severe strokes was similar between EMPA and placebo arm. So this was statistically non-significant, and this is the data on 3-point and 4-point MACE together, and it's again the hazard ratio is less than 1, and CV death where the hazard ratio is 0.62 is a major driving factor which is reduced, which has resulted in a decrease in both 3P MACE and 4P MACE. And now towards another very interesting finding, hospitalization for cardiac failure. Recently, some of the gliptin trials have shown slight increase in the hospitalizations for cardiac failure, which has raised some amount of concern. Here, surprisingly, there is a reduction by 35% reduction. And these again have started separating, the two curves have started separating as early as 2 weeks of initiating the clinical trial. And if you are to analyze the subgroup of 10 and 25 separate, again there is no difference, and it is the same with both the doses. And Empagliflozin as a group, irrespective of the dosages, will reduce the chances of hospitalization for cardiac failure, and that is again statistically significant. This is the all-cause mortality, reduced by 32% with Empagliflozin, a hazard ratio 0.68, and this is a subgroup analysis, and there is a reduction, significant reduction with both the doses, and there is no difference between 10 and 25 milligram on all-cause mortality. And this is all-cause mortality, CV death and non-CV death together. The reduction in the all-cause mortality is again driven primarily by reduction in the cardiovascular deaths. And a little bit of discussion on the safety and tolerability of this drug. These are the major adverse events, and these are the serious adverse events, and numerically more in the placebo arm. None of the adverse events led to significant discontinuation of the trial drug, and these were the urinary tract infections. We were concerned about the urinary tract infections with gliflozins, but here it was non-significant. If you look at the numbers, it's similar between the placebo and the EMPA arms, with a slight increase in females, but statistically not significant. Complicated urinary infections again were very low in incidence, and these were the genital infections, and here you have a statistical significance. Genital infections were significantly more, 6.3% versus 1.8% in the placebo arm, and those infections were more in females. And the confirmed hypoglycemic adverse events were the same across the 3 arms in the placebo and in the EMPA arms. There were no differences. Ketoacidosis, the occurrence of ketoacidosis of less than 0.1% was even less even in the general type 2 diabetes population, and it was not statistically significant at all, and EMPA didn't lead on to any kidney injury. It didn't enhance any hepatic injury. There were no hypersensitivity reactions which are significant between the arms, and there again is a concern with bone fractures with some of the gliflozins. But in this trial, the bone fracture rates were similar, 3.9 versus 3.9 between EMPA and placebo arms. So here you have a clinical trial, we have a cardiovascular outcome trial which has got a huge impact on our clinical practice, and this clinical trial results will have a significant influence on the future design of the clinical, not only clinical trials, but the diabetes clinical scenario, while reshaping and redesigning the clinical guidelines for the treatment of diabetes. And what are the implications when we have a scenario where multiple factors are being related to the cardiovascular risk? You have a reduction in the BP, which could have resulted from osmotic diuresis, reduction in the arterial stiffness, there is no increase in the heart rate, no reduction in the sympathetic nervous system activity, reducing the body weight, specifically addressing the visceral adiposity. It has got antioxidant effects. It is reducing the glucagon levels and enhancing the and reducing the insulin levels. It raises both LDL and HDL, but the LDL-HDL ratio is maintained. It lowers the uric acid levels. It reverses the albuminuria. So what are the implications? Definitely it will have implications in the future practice of diabetes, especially in patients with high cardiovascular risk. And let me move on to a little bit of history. This is the number needed to treat to prevent one death across major trials in patients with high cardiovascular risk. This is not essentially diabetes, and this is a pre-statin era, the FOREST trial, the Scandinavian simvastatin survival study. 30 patients need to be treated for 5.4 years to prevent one death. And only 5% of those were having diabetes. And this is in 2000 when HOPE trial was published with Ramipril. And here you can prevent one death by treating 56 patients over a period of 5 years, and among them there was a substantial number with diabetes and having hypertension. And now in 2015, on top of all other therapies, on top of standard of care, in this clinical trial we had more than 80% of subjects on HCA and ARB and more than 75% of patients on statins. You need to treat 39 patients for just 3 years to prevent one death. In other words, with Empagliflozin on top of standard of care in 1000 patients with diabetes for 3 years, it can result in the following benefits. You save 25 lives, you prevent 14 hospitalizations due to cardiac failure, you save 22 deaths due to heart attacks at the expense of, just at the risk of 7 additional genital infections which are easily preventable and very easily treatable. And these findings due to empagliflozin could be because of multifactorial risk reduction. And this is similar to those observations we had in the STENO-2 trial. And sharing our experience from our hospital, the Jothydev Diabetes Research Centers in Kerala. Since 1997, we have been using a telemedicine-based follow-up diabetes telemanagement system for our patients, where we have been addressing multiple factors. Periodic education via the phone or email or through the website, modifying the medications, lifestyles, diet and exercise regularly over the phone, email or through the website. And we have been observing similar reductions in the morbidity and mortality in those patients undergoing continuing care and periodic education and modifications via the diabetes telemanagement system. In summary, EMPA-REG outcome has resulted in a reduced risk for 3-point MACE by 14%. Empagliflozin is associated with not only a reduction in the A1C, but it reduces HbA1c without any additional risk of hypoglycemia, simultaneously with reductions in body weight and blood pressure, maintaining the LDL-HDL ratio, associated with a non-significant minimal increase in the genital infections. In summary, these numbers are so significant, very attractive. Empagliflozin reduced CV death by 38%. It reduces hospitalization for cardiac failure by 35%. And all-cause mortality, the relative risk reduction is 32%. Some of these observations are probably hard to believe. It is very hard to believe. However, you need to believe. You need to believe, and we will soon, very soon start experiencing the benefits of these observations. And thank you so much for being with us for this month's GEMS video, which is specifically meant for physicians, but of course I have made it similar for the general audience. And this is Jothydev Diabetes Centers from Kerala with GEMS video team, and our aim is education. And we have hundreds of videos on YouTube, and thank you so much for your support, and thanks for your precious time. Until next month, bye bye from Jothydev Diabetes Centers in Kerala.